Okay, first of all, I mentioned that, that I have all these various things. I'm a clinician, for a researcher, medical director of a DNA testing company. But in terms of this talk right now, there are three issues that I have experience with or that I have interests on. First of all is that for over 20 years now, I've been running I have a large population of patients with mitochondrial disease, in particular with a lot of functional issues, cyclic vomiting, autism, pain, fatigue, depression, anxiety, dysautonomia. There's many, many other issues in regards to that. When I have surveyed my patients, about half of them have said that they have been under investigation at some point for fictitious disorder. With all these different synonyms out there, I think I used MCA on the slides. That's short. But it's easier to say fictitious by proxy or just, I'll probably use all the different names. But anyway, somewhere along the spectrum. Half of them, that's really, really high. I can say one thing, several of the patients that said no, there were investigations. They didn't know it. In some cases, I had conferences with other physicians, and we discussed things back and forth, and we didn't always come to an agreement, but at the end it was decided there was not enough evidence to proceed. The family never found out about it. That's really the way that it should go. When there is a consideration that somebody has an issue, that they bring it up to the other providers, that we get everyone involved. We got social workers, we had nursing that had direct observation, we had physicians, in some cases we had a bioethicist involved, and we discussed all the issues, and we, in some cases, decided to file. Not many. Other cases we decided that there wasn't a problem, and the people that felt that there was a problem felt much better now that their issues were addressed. And other times, I would say the most common situation was somewhere in between. And I'll get to that when I go through a couple cases. There are concerns, there are things that need to be changed on the physician and on the family side, and to make better care for the child and a better experience for the family, and that we were going to act on this as a group, but it wasn't an abuse situation, it wasn't it wasn't child abuse. And its communication is really key on that. The other thing is that, I was a general pediatrician before that, and even when I was a geneticist during most of that 20 years, I acted as a general pediatrician, both inpatient and outpatient. It was an inner city emergency room and all that entails. It was very busy. A lot of people went through there from all walks of life. We had rich people that flew in from other countries, as well as poor people that lived next door, and everything in between. And unfortunately, there were a lot of issues of child abuse or child abuse consideration, that there was allegations. Sometimes the investigations found that there wasn't. Sometimes they found that there were. Sometimes there were very heart-wrenching decisions in the middle, and we couldn't tell. Is that directed for me? Okay, all right. Oh, okay, all right. But there were cases that I filed with the government, with the agencies. There were cases that were filed by others that I spoke to Child Protective Services and felt that there wasn't abuse, and why. And there were a lot of situations in which I was interviewed and I really didn't have opinion because I didn't know the case well enough, but I said that I hadn't seen any problems or what I had seen. So I've been involved in this in all different situations, including I've seen real medical child abuse or Munchausen by proxy, and I'll go over that. And then the other thing is that as an expert witness, because of my knowledge on mitochondrial disease and functional disease, and there's very few doctors that are interested in functional disease, you probably realize that. I've been involved in legal cases all across the country and all regions of this country. And most of those have been under Child Protective Services. There have been a small number of cases that have been in criminal courts, and there have been cases in civil courts, basically a divorce situation where one parent said it was this and another parent said it was different, and then they fought it out that way. And I've been involved in many different levels of this, from being, as a treating physician that I've been, been at court and discussing what I've seen and what I think, to the expert in a case that hasn't seen the patient before but reviewed the chart and gave an opinion. So I've seen the way that this has gone throughout the country and how it's been changing. I've already spoke about all 5 of these. I'm not going to go over this again, but they're everything between I'm going to use this off-label. Helen, who has a very serious mutation that eventually did take her life, to Peyton, who was disabled by her disease and now is completely normal, minus a tiny bit of fatigue, and everything in between. Children with autism, with mental retardation, normal intelligence, growth retardation, normal size. I mean, just across the spectrum. Mitochondrial disease can look like many different things because you're talking about at least 1,000 different genes that make a mitochondria. Even within the family, even within identical twins, you can have completely different outcomes. Every part of the body requires energy, so you're going to see many different manifestations. You can see that the complexity of this is beyond what the vast majority of physicians can understand. And that's what the problem is here, is that the complexity is really beyond what they can understand. And even though you do have some experts, and a lot of physicians out there are well-meaning, you can't be an expert at everything. This is not the only rare disease or semi-rare disease, rare-like disease out there that they need to know about. With increased technology, there are a very large number of rare and apparently rare conditions for physicians to learn, and there's just not enough time for them to do so. So I'm going to go over 3 cases. I have changed names and I have changed some of the facts, and I have left out a lot of the things because these are areas that are somewhat of concern. But the important facts are real. These are real kids, and the important facts are here. But can most of you read this? Raise your hand if you can't read it. Oh boy. Okay. I'm going to have to... Yeah, I mean, usually we have these huge screens in rooms. Okay, I'm going to just go ahead. It's a 3-year-old boy with mild developmental delay, hypotonia, and muscle weakness. A diagnosis of and this was in the early 1990s, okay? A probable mitochondrial disease diagnosis was based on the phenotype, meaning what the child has, the biochemistry, looking at blood in the urine, showing, if there's signs of energy metabolism, apparent maternal inheritance, so the pedigree looked like a mitochondrial DNA disorder, and apparent clinical improvement cofactor. In other words, you put them on CoQ10, you put them on carnitine, kid seems to get better. Okay, so this used to be the basis of a lot of these cases. Is that, it was based upon the medicine. We had history, physical examination. Yeah, we had some laboratory testing. It all pointed towards a mitochondrial disease, but we never got an exact disorder. That was the technology that was available at the time. Muscle biopsy is very invasive and wasn't often done in these sort of cases. The mother had 8 children, all of which had some degree of developmental delay. This was the most affected child, who also had significant muscle weakness. I don't want to go into this very much because otherwise the case would be pretty obvious, but the mother was disowned by her mother and her entire family for complicated things that came out of the workup and everything. Is that when you do a family history, you find things that are family secrets, and the mother was being ostracized for identifying certain family secrets. And the entire family left her. And so she was alone with a husband that was working as much as possible to try to keep up their income, and 8 affected children. The child then started developing episodes of hypernatremia, that sodium, the blood salt. So the blood salt or the blood sodium would go sky high. The blood would become alkalotic, high pH, the absence of acidosis, and would start vomiting blood. 2 of these episodes were life-threatening. We had to resuscitate the child. The child almost died, very close to dying, and was given blood transfusions and put in the ICU for several days. The child then stabilized and went back to his previous baseline, which is basically a normal child with some muscle weakness, a little bit of developmental delay, but basically a normal child. This happened a few times, And there were some smaller episodes in which the child seemed to be kind of sick and had some bloody diarrhea. And no apparent medical cause was identified. And the last one there is a much younger Dr. Boles was the attending physician. That was about 25 years ago. And nobody knew what to do. It was my patient, I was the geneticist, and so they kind of left it up to me, and nobody had any idea. So, okay, I want to open this up for discussion. I want to say, what do people think about this case? I mean, what would you think about it? Put yourself in my shoes at that time. This is a child who's having very, very serious conditions, almost died twice and was very sick, was in and out of the hospital for a few months. Nobody could figure out what's going on here. Does anyone have any ideas? What would you do? What would you be thinking? The patient had earlier responded somewhat to carnitine and coenzyme Q10, got a little better. It's hard to say. You know, it's these things, I mean, seem to have more energy, seem to perk up more. There's no proof of anything. Yeah? The child now has normal diet. This child is really not medicalized at all. Child is on CoQ, carnitine, they're over-the-counter vitamins. Other than that, the child has, I mean, the child's in special schools to try to catch the child up to normal, but I mean, it's really non-medicalized. You have it.
Was the sodium elevated at the time during the hospitalization?
The sodium is normally, the sodium at clinic visits is normal. But when the child is basically in coma and vomiting blood, the sodium is sky high. Yeah. Yes, the extended family is rallying around here because the child is deathly ill. Yeah. I mean, I'm sure it, you know, in this sort of a situation, it raises some eyebrows, but I think most families would probably. Well, there's the seven siblings with some degree of developmental delay. Most of them are learning disabilities.
On the mother's side, I mean,
and mother has some learning disabilities, some minor developmental delay. I mean, I didn't do an IQ test on her, but she seems to have some mild cognitive problems, but she's not significantly retarded by any means. Yeah.
Was there any chance that there was a chromosomal deletion that some family members were clinically affected by and the others were not?
Well, I mean, we did the chromosomal test that we could do in the 1990s, and it was normal. I have not tested this patient with recent genetics. I lost track of this family about 7 years or so after this. Yeah. No. I know, it's kind of perplexing. Okay, after the third time the patient went to the ICU, I said we had a catheter in, we're going to draw blood every 4 hours to try to see what's going on. What happened is that the sodium and the pH of the blood, the bicarbonate level, was completely normal, even up to an hour before an event that took the child to the ICU and almost killed the child. At that time, the sodium was the highest as anyone's ever seen before. And the bicarbonate level was also sky high. The patient had blood coming out of both ends. Video EEG was ordered. This is 1990 technology. This is a camera which is larger than most television sets, aimed at the bed with I kid you not, it's about that long, about that wide, and about that tall, full of electronics with a big, huge mother of all cameras sitting on top, pointed at this child's bed with you know, like at least 40 wires attached to this child's head to see if there's any seizures or anything, with the wires going to this video thing. And so we had a lot of normal video and normal EEG. Yeah?
Was the mother around all the time?
Yes. No, that's a good question. That was brought up at the time. I mean, what was brought at the time is that the mother was there at every single instant that anything happened. but that at least half the kids in the ICU, the mother was there all the time.
So you're going to think it's like one child.
Well, that's at this point what I was thinking. Because I didn't have, I had gotten to the place that they're saying that these other doctors gotten to. I have a child who has been critically ill in multiple cases and may not survive the next one. I have no medical explanation for this. I figured, well, maybe that there's a seizure or something and that this is some sort of bizarre seizure-related thing, but there's no abnormalities on the EEG. With that camera facing towards the bed, you think that might scare off if there was any sort of Munchausen. Yeah?
With a channelopathy or something?
I have not. That was before we even knew this existed. That could very well be what the underlying well, I'll tell you what I did, okay? I turned the monitor off, okay? Because, you have this big console here and you have a TV in there. I turned the monitor off, but I left the camera on. And it found Mom going to the cabinet, getting a huge syringe, a 70 cc syringe. It's just this big in diameter and that long, mixing some stuff up, putting it in the syringe and putting it in the child's G-tube before the child got ill. Called security. Security said they cannot do it without a warrant, but they can ask. The security asked if they can go for the mother's purse. They found the syringe and they found Alka-Seltzer tins. Lots of Alka-Seltzer tins. Alka-Seltzer is sodium, bicarbonate, and aspirin. Aspirin causes GI bleeding, and the sodium bicarbonate causes the sodium and the bicarb to go high. Probably having to tell the mom what we found and that with a policeman in the room was one of the most difficult things I've gone through in my life. She eventually plea bargained and did a very hard time. Okay, what I want to mention this is that this really does happen. I've seen at least 100 cases in which medical child abuse or fictitious disorder by proxy was considered. We'll just assume that this is not going to be readable, but when it gets later on, if you're interested in a case and stuff, it'll be available. This is case 2, Bailey, again, not her real name, early 2010, so a few years ago. Previously normal, intelligent, early adolescent girl suffered from multiple functional symptoms that started after an apparent stomach flu. So at around 10 years of age, she got stomach flu, and after that, she had severe dysmotility. Required 2 feedings and eventually required full TPN. So she's not eating by mouth because when she eats by mouth, her stomach blows up and then she gets very sick and vomits. She has chronic fatigue syndrome, chronic pain in multiple locations, and unexplained tachycardia. Again, I'm trying to keep this vague. I left some things out. I don't want to say the locations of the pain. It's really not important for this case, just to say that she had very severe pain that no one could explain. Probable mitochondrial diagnosis was based upon the patient's phenotype or the type of things that were done. There was apparent maternal inheritance. There was biochemical tests. The child got better. It was a young adolescent at that point on cofactor therapy, and also there was a mitochondrial DNA variant that I felt was probably one of the major causes of the illness. So we're now in the 1990s. We now have some molecular techniques. It was a mitochondrial DNA variant that I'd never seen before. I can't prove that it causes disease, but it looked like it very much might. And it fits the mother's family. It has a lot of people with a lot of functional disease and problems. So we have a diagnosis, but we have a diagnosis which is somewhat controversial, and we have a prove anything, but it's suspicious. Then she started to develop additional features. Anemia requiring multiple transfusions. She had her hematocrit, her amount of blood, would be normal, and then it would come down pretty fast. And transfusions was going in and out of the hospital for blood transfusions. Hem-onc was called, and they couldn't figure out what was wrong with her. It didn't make any sense to her at all. Several hem-oncs in several different states. But what she really got that was the problem was these dysautonomic reactions. These dysautonomic reactions, whoops. Glad you can't read that. The dysautonomic reactions would be that she would get pale, she would get tired, she would get lethargic, her blood pressure would drop, and sometimes she would just get some IV fluids and would get better, and people would question, why is she getting IV fluids? At other times she crashed and was in the ICU in essentially critical condition with very low blood pressure and was on medications to maintain her blood pressure. No one could figure out why she had these episodes. The local physicians could not identify an apparent medical cause for neither the severe anemia nor the life-threatening episodes of shock. This was basically shock. Sometimes they would grow bacteria out of the blood, and they weren't sure if that was a contaminant or if it was real sepsis. Most of the time she had this, the blood cultures were normal, and they couldn't find anything. Apparently that she had a viral infection because she had signs of a viral infection on a lot of these. And sometimes the family had like a cold or something, but just a regular cold would do this to her. So, after having been primed to the first case, what are people thinking here? This is 20 years later for me. Where do you go on a situation like this? Yeah, go ahead. That was one of the, she actually had a really good GI specialist. He was one of the primary people of the care team, still following the patient. Celiac had been ruled out. That was a good, yeah.
Did you have like a tube or anything?
She had a tube into the somewhere. It's a tube somewhere into some part of the abdomen, and she also has TPN. During most of these, she was on TPN. She couldn't tolerate almost anything enterally, by mouth or by tube. Yeah.
She has some mast cell dysfunction?
She had what?
Some mast cell dysfunction, some immunological dysfunction?
Yeah, but no, that had been looked into. But yeah, I mean, basically what people are saying is they're thinking of all the different things that can do this. And there were several different hospitals involved in different states. Okay, well, anyway, they suspected medical child abuse and had filed. And then the family, they filed, there was an investigation, it was unconclusive. Then the family decided they really want to have another opinion, so they went yet to another state, to another medical facility, where immediately they had figured out that this is doctor shopping and Munchausen by proxy, and what they did is they took this now mid-teenage girl and they kept her in a room against her will and said the parents couldn't contact her in any way, convinced that she had a psychiatric condition, that she could eat and that she wasn't eating, and they figured if they could just take away the brainwashing from the mother, that she would eventually realize that she's okay, even though that she was completely telling them that they were wrong and was fighting them a second on this. They took off the mitochondrial cocktail, and the physicians and the hospital did not contact her previous medical providers. In fact, when the previous medical providers tried to contact the hospital, their calls and emails were never returned. What are people thinking now? I'd say what? So anyone, it's pretty scary, huh? I mean, okay. The condition deteriorated through the separation. Under increasing legal pressure, much of it was from me, I had contacted this child and family services in that state and told them that the hospital had lied to them and said that the physicians believed it was medical child abuse, but they never told you they were physicians in several other states that had been following this family for years, and that we believed the family and we believed the patient. And under that sort of situation, they caved. They allowed the patient to then go back home to one of the physicians who had been following the patient for a decade to be the primary provider. She has gotten a lot better. It's been a few years now. She's in college, away college now, in another state than where they live. They live in a small state, so there's not much in their state, but so that's everything is in different states. It's not so much doctor shopping, but because of opportunity. We did, one of the things I've been trying to do the whole time is get exome sequencing, where you sequence all of the genes, and they refused to do that at the hospital, where the two hospitals in two different states where they declared it was child abuse. Finally, the financial situation is worked out. I don't know how. We got exome sequencing. We found the one gene in the mitochondria, which I'd seen before, one gene in an Ehlers-Danlos gene that describes the dysautonomia, and one mutation in a black Venn diamond gene that explains the anemia. 3 mutations and 3 different genes explaining all different parts of her problem. She's now on the therapy and doing much better. All the legal action was eventually dropped, but it wasn't easy. They had to hire attorneys and everything and come after them. And they finally agreed to the hospital dug in on this one, not unlike the Pelletier case. And they were, double for nothing, triple for nothing, and they just kept, raising the ante. They were very sure until it got to the point that, the legal system and the government had to kick in and tell them that they weren't going to win this one. So, yeah.
Is there any option to follow up action on the hospital or refusing to help with the patient or the doctors, or is that causing you difficult in the situation?
Without going into detail that would give this family away, which is definitely afraid that this will get out, and because of their incredible embarrassment about the situation, they know this has been this has been proven. All the doctors that are following this patient now completely believe in the family and everything. It's just that they were so traumatized by this and everything, their good name being thrown for them, they want to keep this separate. Okay, there has been some consideration of legal avenues. It's really up to the family to decide whether they want to make this public or not, because that's what it would do. Yeah, that's really what it would do. I mean, from my own perspective, I would hope that they would to get this out there, but from their perspective, I totally, I respect their wishes to just let this go. Okay, these cases have very different outcomes, but they had similar beginnings. They're non-specific clinical findings. A clinical diagnosis of mitochondrial disease that was not proven and was challenged by some physicians in both cases. Okay, later development of severe life-threatening intermittent manifestations, and the inability of the physicians to medically account for later developments. In particular, in the second case, the dysautonomic reactions can occur in mitochondrial disease, but they're usually not that severe by any means. And anemia can occur in mitochondrial disease, but not that severe. We later found other genes outside of the mitochondria that accounted for that. Does she have a mitochondrial disease? Well, she also has Ehlers-Danlos, and she also has black Venn diamond. What do you call it? I mean, it's just, 3 different things that caused her complex medical problem, and that is not that unusual. Sorry, I'm behind the pillar, aren't I? Okay. So what was missed in the second case? Obviously things didn't go right in the second case. There was no communication with the previous physicians. No attempt to order additional testing. I asked the hospital. I spoke to a few people that I finally could get through to. The person I did get through to said, I would love to order that test, but the hospital is so set in this situation, if I even bring up this case, I'm going to get fired. And even in the face of continued deterioration, the hospital will continue with the assessment and plan. That's one of the things, if it doesn't work, you keep going. They just thought that this teenager was digging herself in. And she wasn't going to accept the fact that her mother brought her to this position, because she didn't. But anyway, the communication thing is the main thing here. With the they blew it. I mean, they said, and people blow it. Doctors do that. Doctors make mistakes. These are very complex situations. You can't practice as long as I have and not have made some mistakes. The issue is that you learn from it and you grow from it. And where they blew it is that they decided not to communicate with the other physicians. I mean, that was the major, yeah.
It's a very important point. Dr. Boles told us just earlier is that even Jenny and Rossler, who put forward the medical child abuse concept, their first recommendation is that everyone must talk, everyone must communicate, so that everyone is aware of what everyone is seeing in a particular case that is working, but it's not followed. And this to the detriment of the patient. I'm actually, so there's clearly a need for a protocol that is broad, that is accepted by those that have an interest in the child protection system, and those that care for patients with rare disease. And I might say that RNE, in conjunction with NORD, the National Organization of Rare Diseases, is trying to establish that bridge with the Child Protection Society, that we develop an agreed-upon protocol that is acceptable and should be, and to create a template that is what is put in front of every case that comes forward, that is the recommendation for both sides. And not to do so would simply be malpractice.
A couple of statements. What happens when you do bring your doctor, like Dr. Clausen, into a hospital situation and they don't listen? The parents know them.
Quite ironic with us. Because there's been, for both of us, there's been very well publicized cases in which they didn't listen to us.
And that's what happened. When my daughter was during the time of Justina Pelletier, and Yale called us back in and said she has Dr. Clausen's disease and was surrounded by police, and they took her away. Now, this has happened repeatedly to us. I told neural doctors, many of them had their rare diseases before they ever entered my life. It doesn't matter. How do we change the culture in the hospital? There's a fear of making an error. There is all this competition. There is arrogance. That's where it has to change.
Psychologists.
Yeah. There were two studies done recently, one at Harvard and one at Johns Hopkins, on the frequency, the statistical frequency of misdiagnosis. They surveyed primary care providers, and they found that even with normal diseases like otitis media, strep throat, there was only a 50% accuracy rate. Yet over 70% of those physicians felt they were correct. And that when it came to rare diseases, they were accurate less than 30% of the time. But 77% of those primary care providers were sure they were correct. They would not send out referrals to consult. They would not do more studies.
No, I understand completely. You kind of brought up two different areas, if I can separate those, okay? First of all is that the complexity of medicine and biology has gotten to the point that there's very few doctors in the world that can understand any given area, and there's no doctor in the world that understands every area. And when you're in primary care, you're several decades behind by necessity, because it's just gotten so complex. And it's one of the things that we're working with is trying to get advanced knowledge so that everyone can use it, and that is not that easy because it is very complex and it takes a long time to understand it, but to at least make it available for those doctors that want to make it available. The second thing is that you brought up every evil that people have in general. This is across societies and across, and across specialties and outside of medicine. I mean, people make mistakes. People are arrogant. People have opinions. People just, don't believe others, and they feel that they're own right. This is just across the board. We can't necessarily change human nature, but what we can think is, like what Dr. Corson said, is that we can try to make protocols that child abuse specialists and rare disease specialists agree to, and that families and medical ethicists sign on to, and psychologists and pain specialists and everything. And that's really what this conference is the first dialogue, to come up with ideas for protocols that are best practices. And so when arrogant people think that they're right, their hospital attorney will say, well, we have this protocol here we have to follow. Speaking to the camera. Yeah, okay, go.
I'm a medical social worker. I work on a floor in Albany, where that's unique and complex cases. That was where I came from.
Okay. No, that's
And that's why I'm being concerned.
it's a really valid question, and I will try to be arrogant here and try to answer. There's other people involved, and they could correct me, and we're only halfway through the first day, and we're going to be here tomorrow, okay? But, I mean, in addition to educating all of you and have you go back and change your worlds, right? We're, to some degree, speaking to the cameras so that people in the United States and indeed all over the world, if they have questions regarding this, they can look at this and they can see what the rights are, what the responsibilities are, where the limitations are, and maybe get educated. But also, what I'd like to do is to have a first dialogue. And to some degree, the first dialogue is you have to start somewhere. And even though this is a small little conference in a furniture store, everything's got to start somewhere. Yeah.
One lawyer that I've spoken to many times, but this has happened to me repeatedly, has suggested, and I'm in the midst of doing it, anybody that's interested, in filing a criminal lawsuit under the protected class of children for adults with disabilities.
I know nothing about that. You ought to talk to some attorneys about that, but yeah.
People ignored. There is a group of people that are interested, but I don't have an attorney. I'm trying to do this on my own.
Okay.
So if there are any attorneys in this group,
Okay.
who would like to-
I'm going to have to, if you can, yeah. You can take a microphone? Oh, here. Yeah, sorry. I can't hear you. I don't know. Yeah.
My question is, it's not really a question actually. You mentioned about the team. You talked about the guys outside the hospital that they want to discuss. They want what to be kids in the hospital or what. What I think my other problem is that the hospital itself doesn't know the doctors within their hospital that have special conditions. You might think, oh, well, that's wrong. But I know that they do hospitals that the one division that we know let's say this hospital, they can consult with the home. This is the question. And there was a confirmed communication. So that's
I can't answer regarding this case without going for confidentiality, but in general, it's often that, that nobody really knows what sort of abilities they have and things, and there really is. The subspecialties that come, subspecialties like you're expert in mitochondrial disease or Ehlers-Danlos or something like that are really very, very, it's not in structure really to handle that yet for groups. Yes. Oh. Okay, you want to do the microphone? Okay, I need to go for some more slides here.
I have a question in a different direction. I work in the computer field, including some colleagues where I'm based in the Watson system for the future of medical diagnostics. I'm curious to what extent you're optimistic or pessimistic about the ability of very easy, robust medical databases to help with diagnosis of rare disorders, where there are, as you and others have been saying, sometimes very rarely come across a certain thing, have difficulty recognizing that, not know the resources within their own network, so people know.
Well, I mean, they are helping. I've seen many diagnoses made by primary care physicians that had done that, come up with diagnoses they never heard of before on a computer database. Problem is when you're in like an HMO or a government system, like a Medicaid practice, you're seeing a patient every 10 minutes. You don't have any time to say hello, goodbye, here's a prescription.
So you mean
I mean, that's one of the major problems, is that the people that do this tend to be private providers. Okay, I just want to go one last case, okay? Because I made it black and white on purpose. I wanted to say that the whole world is mostly gray. Okay? There were, this is a 6-year-old with intestinal pseudo-obstruction. Chronic pain syndrome, including somatic and visceral hypersensitivity, generalized dysautonomia, including unexplained tachycardia and ADHD. She had a probable mitochondrial diagnosis based on phenotype, apparent maternal inheritance, muscle biopsy, and apparent clinical involvement with cofactor therapy made by a very well-known geneticist. To keep anonymity, I can't say anymore. Anonymity, I can't say anymore. Caitlin, which is also obviously not her real name, presented to emergency rooms multiple times. Her care continued to escalate. Her feeding intolerance got worse. She eventually got tube fed, and eventually that didn't work, and she was put on TPN. She also needed to go for additional IV fluids every once in a while. She had multiple hospitalizations for fever or tachycardia, because now she has a central line. Every time she has a fever, she has to she has to go to the emergency room. She's evaluated. They take cultures. They say, oh, well, you might have a line infection. You need to come to the hospital. Sometimes she had line infections. Most of the time she didn't. She was put on oxygen and BiPAP, a machine basically to put continuous pressure at night. She was put on IVIG and on narcotics. She was on a lot of narcotics that kind of snowed her out because of all the pain. And she presented to another facility. That often comes up here. And at that other facility, they could find no apparent medical reason to justify all of her problems. Any quick comments as to what you think this one?
It could be a multitude that you had mentioned before. The person who had 3 different things going on.
Okay. Suspected multiple, medical child abuse was reported. She was held in the hospital against her mother's will for months. There was limited and supervised visitation. The hospital and the physicians had limited communication with their previous providers. She was successfully weaned off of all of the unusual care. She was taken off of the narcotics, off of the IVIG, off of the tube feedings, off of the TPN, off of the BiPAP, and off of the oxygen. Her diet was expanded. The mitochondrial cocktail was discontinued. She was in good condition on admission. She remained in good condition, and she was discharged to foster care.
How can all of that be created?
What is going on here?
Insurance was out. She's in a remission period. She stayed up.
Well, there are non-specific clinical findings. There's a clinical diagnosis of mitochondrial disease, and while there are the criteria that are usually used for mitochondrial disease, there's no proof in this case. There was no molecular, and I'm sorry to say that there is no molecular. I have not been able to get the testing because the family doesn't have the resources. They don't have the insurance that we'll pay for. So we don't have an exact diagnosis, but it looks like to me that it is mitochondrial disease. She again developed late onset, later severe manifestations that are life-threatening or could be life-threatening. She had a Lyme sepsis twice that brought her to the ICU. She could have died from Lyme sepsis, so this is not just something that that she's not eating or something. And the inability of the physicians to account for her problems. They didn't believe that she needed all that stuff, and in retrospect, they were correct. She didn't need all that stuff. So, what are the medical and legal teams not thinking here? The medical and legal teams are thinking that the mom is crazy and that she came into the hospital saying that her child was ill when the child was not ill and made the medical team do all of this. Mother's not writing for all of this. When I got onto this case and I went through the charts, I was just totally amazed. She'd have a slight increase in the temperature and her heart rate would go up. That's mitochondrial disease. The temperature goes up all the time. I tell people not to take the temperature. Her heart rate would go up a little bit. That happens all the time in mitochondrial disease. So they put her into the hospital for rule out sepsis. And of course, while she's in the hospital, she gets an infection because there's all these sick kids there. And she stays in the hospital for a while. Her mother said that she had nausea, so they would change the formula. The mother was hypervigilant. She was concerned about what was wrong. She cared about her child deeply. Her child would show some discomfort, and she would say, "My kid's not tolerating it." But there would be a doctor that wrote for the tube, a doctor that wrote for the lung, a doctor that wrote for the TPN. I mean, this is a dance of two. The mother is saying that there's a problem and someone is writing for it. The problem is she's always going into another emergency room and sees another doctor. So when you have a GI specialist, you have a cardiologist, you have a pediatrician, you have a Lyme specialist, you have infectious disease, and on and on and on. And those services rotate every month. And you have an attending, you have a resident, you have a medical student, you have another, and every month. So in one facility, you can rack up 100 doctors really fast. But she didn't like the medical care because her kid is still sick, and she went to another facility. She did a doctor's job. This is her second place. And all the thing is, she was at one facility. All of her providers knew what the other providers had done. It's all in the medical record. Mom told them. Mom was a good historian. They all knew what the situation was. But who is responsible for unnecessary escalation of care when the absence of fraud? I went through the entire chart and I could not find a single instance in which the mother had lied or misrepresented. Saying that my child is nausea and that she can't tolerate it, the child herself saying she has a stomachache is not fraud. It's maybe hypervigilance, but it's not fraud. Following my testimony, what they did is that they said, I don't see how the mother is a risk to the patient because she didn't do any of this. She feels really horrible about it. She's very glad that the child is off of all these treatments and is eating. Does her child have stomach aches? Yes. Does her stomach have fatigue? Yes. Does she have tachycardia? Yes. Does her fever go up every once in a while? We don't take it anymore. Yeah, she has mitochondrial disease. There's no doubt about that. She has a lot of dysautonomia. But she's on a normal diet now. So I think she gets a little bit of tube feed. She's on some GI medication. I think that she's on some neuropathic pain because she does get pain. So she's on like a drug for neuropathic pain. She's on a regular diet, basically. And she's a normal kid now in school and everything. The grandmother is taking care of her medical needs. She has medical custody. But the mother lives in the house, and the mother basically is acting like a mother. It's just when it goes to the emergency room, grandma comes by. Grandma signs some papers. And she's been doing fine. There's been no problem. This is a situation in which a mother was hypervigilant and was scared. And there is a risk. I brought up in the first one on purpose is that if you have fasting intolerance and you don't eat, or if you have a 5 fever and you get septic or something, there is a risk. Mom would come into an emergency room with a doctor's note saying, if my child is ABC, you need to do these things. And they would do it. Would they ever contact the doctor? Was their primary care provider involved? There was no core. It was mother in an emergency room and an intern who hadn't slept in who knows how many days, who followed the note to a T. And this is what happened. Every time we went to a new gastroenterologist because it was a major medical facility, there was always another resident on. They'd say, oh, you're still having stomach aches, let's do this, let's do that. Yeah.
One point about that is often, people would come to us as clinicians and say, diagnosis is protective, but diagnosis, 1, is not necessarily protective. 2, because if one wanted to do harm or over-medicalize a child, you could do that even with the diagnosis in place. And 2, that was point 1. Point 2, there's no point. What's important is really the symptoms, because especially with mitochondrial disease, ALS, NALS, many of those disorders, there is no specific treatment for it, at least not yet. In which case, the treatment for the symptoms is often going to be the same thing, whether or not you have a diagnosis in place. So the focus, yes, diagnosis is important, but over-medicalization is often determined by whether there's excessive amount of therapy for the symptoms that are there, regardless of why the symptoms are there. So, just as an FYI.
One more question, and then I have to wrap up right now.
Can you comment on the law in Massachusetts, the Boles law? It's the end of life.
I'm from California. I know nothing about it. Maybe someone can do that later.
It's where a physician has to sign your end of life wishes?
I don't know.
Like you can't have a DNR anymore, you have to get signed?
California recently has a law like that too. It hasn't gone into effect, but it was passed.
It goes state by state, all
Yeah,
the states
right.
have it now.
Okay. The last case is probably the most important one to talk about here. I mentioned that there have been cases in which a doctor would call me up and say, I'm really concerned about this case. Take me aside in the hallway, give me an email or something, and we would talk. Sometimes that would just be a talk, and that's all that it was. Sometimes we actually brought in other people, like nurses, some bioethicists, sometimes social workers in particular. They're always involved. And we have to come to a decision because A, there is a diagnosis, or there's not a diagnosis, but there's real symptoms and there's objective disease that people have seen. B, this is serious. We can't just let this go. This child might die or a bad outcome might happen. And C is that we suspect that the mom is doing something against the mom, but it could be someone else. That she's doing something that's facilitating this. And D, we suspect that there are a lot of physicians out there that are doing things that are facilitating this. And we have to say, usually the key is to have a core team. Nothing will be done unless this core team agrees. There'll be like one or two people that can make the decision in the middle of the night, like three people in the middle of the night and have like a powwow or something. And that nothing will be done without one of those people. Then you have alternates in case they're on vacation or unavailable or something. You can't reach them. And that's what we do. Is you're in the emergency room, you have that. I said, well, that sounds okay. Why don't you just get a culture, send them home, get a CBC. If the CBC's not increased, send them home. Don't put them in the hospital for that. Call them back in the morning with a blood culture. Make sure that someone follows up on it. It's not falling through the cracks. Or you could say, I don't know. I don't think that one really should escalate on that. Let's have the GI specialist look at it. Or let's drop the feeds by 10 cc's an hour for 10 hours and then let's put it back up again or something. But the core team can be involved in that and make sure that the escalation, if there is an escalation, is appropriate. And can be involved in that. And the mom feels better about that because she goes into the emergency room with a kid that she's concerned about. And there's somebody there that knows what to do and what not to do. And it's not going to be, oh, you're the Munchausen mom, we're not going to do anything and she'll worry about her kid will die. There's somebody who knows what the risks are and is willing to make sure that her child is protected as much as it's reasonably possible. And that resolves the issue. The other thing that we do is if certain physicians are doing things that are perhaps over-aggressive, often they'll back off and say, oh, I didn't understand all that stuff. Of course I'm going to watch this more carefully. Or we can try to remove this. Or we can wean this. Or let's do this test because I really think the patient needs it. Or, or they can say, no, you're wrong. The patient really needs it, and then we can discuss it. Sometimes they're right. And sometimes the patient does really need it. This patient, this last one I spoke about, she never did get off of the pain med. They did take her off of it, and then her neuropathic pain got really bad, and they put her back on the drugs, and she's doing better. So some of the things, she doesn't need narcotics. She's on other drugs that are not addictive and have far fewer side effects, but she gets pain relief, and she's not in severe pain. She just has a little bit here and there. She can handle it. I mean, she's spoken to me and said, oh, it's okay. Yeah?
Do you think it's important to choose, like if you're going to have a core team in this day and age when there's all these different groups, should you try to choose your core team within one system? Or what if your primary care is outside and you go to Mass General or something?
Well, I mean, yeah, in Los Angeles and in Boston, they say it should be within one system because they like it better that way, but in most of the rest of the country, that's not. This is really common. Multiple hospitalizations with fever and tachycardia, organ failure like bone marrow, anemia, infections are really common. A controversial diagnosis in the absence of proof. We've gone over that. Severe, even life-threatening, intermittent manifestations. They come and they go. And I have the word protein in here. They show up in different ways. This is what drives physicians crazy more than anything else. To talk about case 2, in which it's clearly not abuse whatsoever. Patient has bone marrow failure. They didn't know that. Patient become anemic. They thought she was cutting herself in the shower or something. The patient would get, GI problems and couldn't tolerate feeds. The patient with blood pressure would bottom out and she'd fall down and sometimes she would go into like a coma type situation. None of these things made any sense to anybody. It happened to be those are 3 different mutations and 3 different genes, so there wasn't an underlying cause. But the thing is that the patients that often get to this point are things that nobody can figure out. Part of the problem is the extreme biological and clinical complexity of these cases. None of these are very easy. Part of it is, in some degree, honestly, a failure of Western medicine. Western medicine is really good if you have a tumor or you have a knee problem or something. But if you have fatigue and nausea, it's not so good. Sometimes the other medical things out there actually have better philosophies on this and fit better with the DNA technology that we have. Mental health illnesses come to that all the time. Most people in and out of medicine are of the thought that there's the mind and the body and that they're different entities. And depression and anxiety are due to the mind, and the rest is due to the body, but the mitochondria power the mind. And often the mother has real anxiety or depression from her own mitochondrial disease, and that gets into there. A breakdown of communication, we've already gone over that, and often the presentation of a huge giant chart that no one can understand to a new provider or a new facility is often the last straw.